We're excited to hear from Dr. Devlin about integrating holistic approaches to managing cancer-related pain. We chose today's topic because when you're in pain, it's hard to focus on anything else. We want to share evidence-based pain relief approaches with our multiple myeloma community. With that, I'll go ahead and introduce today's speaker. Dr. Sean Devlin is the Chief Medical Officer at Brio Medical in Scottsdale, Arizona. Dr. Devlin specializes in integrative medicine and integrative oncology. He holds a master's degree in biochemistry from the New Mexico Institute of Mining and Technology and a doctor of osteopathic medicine degree from the University of New England College of Osteopathic Medicine. Dr. Devlin is committed to providing holistic patient-centered care and is passionate about integrative oncology. And Dr. Devlin, I'll now turn the time over to you.
All right. Thank you so much, Cindy. Well, it's a pleasure to be here, and thanks again to HealthTree for making this happen. I have a few slides that I'd like to share and kind of orienting people to what my concepts are around pain and how we help cancer patients manage pain. So I will reach deep into my reserves here and pull that up. And then hopefully you guys can see this.
That looks great. Thank you.
Looking great. Okay, perfect. So at the end of the day, I mean, we don't really break down or silo different cancer diagnoses when it comes to treating pain. And I think cancer patients in general, they struggle with pain. It's probably one of the top three complaints that we hear about when it comes to treating cancer patients and working on supporting the quality of life path that they're on. I looked at some sub aspects of multiple myeloma, and of course, with a large amount of bony involvement and potential kidney involvement, those two areas can be quite painful. And so we'll discuss those throughout the lecture. There's types of pain that we address. A lot of times people are suffering from pain and they may not really care about how we define things because they're suffering. But chronic pain is any sort of long-term pain that lasts greater than 3 months or beyond. Generally, it's due to a degenerative condition. Arthropathies can be caused by, rheumatoid arthritis, osteoarthritis. Prior injuries, of course, diseases like cancer can affect the body in ways that cause pain. In general, we look at anything from compressive or invasive issues with cancer growth in the body, pushing on nerves directly or leading to profound inflammation, which can irritate the nerves, which sends the message back to the body that there's to the brain that says something's wrong with the body. And then things like post-surgical neuropathy. Anytime you cut somebody, you're going to cut nerves, right? So many times folks will heal up and not necessarily deal with any post-surgical pain, but they'll have changes in sensation in that area that was severed. Again, bony involvement is something that's a big concern because that can be very painful and debilitating. And then, of course, invasion of organs, which have only a confined space to sort of live in. And that fascia or that capsular material that holds the organ intact can be compressed in a way that can cause pain. When that happens over the long period of time, it's diagnosed as basically a chronic pain problem. And of course, many years working in the emergency room, we'd see a lot of people with acute pain, generally from trauma and other injuries. Usually this pain is well controlled within the first few days or weeks for preventing it from developing into a chronic condition. We have a lot of tools in our toolbox in the ER, and we're able to control pain basically upon receipt of a patient. And that's one of our first goals, to stabilize a trauma patient. The things that we look at primarily in the acute pain setting is that the goal is to control the pain with a reasonable approach that allows the patient to transition into that healing process without suffering some of the side effects of being on pain medication, which are numerous. Things like constipation, issues with nausea, vomiting, sometimes no longer benefiting from the pain medicine itself and developing a tolerance to it, and then ultimately addiction, which has been obviously in the news for the past decade or so. So there's other types of pain. Between the temporal concept of chronic versus acute, we have neuropathic pain, and that's due to either nerve damage or profound irritation to the nerve. A lot of people will describe these pain issues as either stabbing, burning, or shooting, or sharp cutting pains. can also cause difficulty feeling sensations like heat and cold, and even interfere with our ability to determine what we're touching. Nociceptive pain is generally a result of direct tissue damage, generally again described throbbing, sharp, or achy pain. This pain is caused by an external injury such as falling, bumping into things, or being hit, by a vehicle or another person. Stubbing your toe is probably one of the most, I guess, common examples of nociceptive pain. Psychogenic pain, this gets a little deeper into what we've described in the past, and it's a little bit of an archaic term, the psychogenic pain, but basically it's a physical pain without evidence of a physical injury, and it's caused by a variety of psychological factors from fear, depression, stress, anxiety. All these things compound the brain's perception of the pain we're feeling. A lot of people who develop these issues have underlying, maybe possibly mental health issues or traumas that haven't been dealt with. Psychological pain is something that we'd refer to as like the emotional heartache that you go through with the loss of a loved one or breakup of a marriage or a relationship. And it's, causing a bunch of emotions to rise: sadness, anger, anxiety, shame, guilt. When you're talking about the cancer patient, this is pretty common, and it's common for a variety of reasons. Number one is a lot of folks feel as though that their cancer was given to them, or they developed cancer possibly because something they did or a lifestyle choice they made, and they can develop shame and guilt around that. And of course, the diagnosis itself can bring up obviously sadness, anger, anxiety, and like a woulda, coulda, shoulda, like, is there something that I could have done to prevent this? And now that I have this, I have to now face a potential onslaught of, surgeries, chemotherapy, targeted therapies, radiation, processes that I don't even want to imagine because of the fear associated with the idea of having cancer. So that's kind of a psychological pain component. And then there's things like radicular pain, where there's spinal nerve compression that causes pain to be radiated or referred into the limbs or up and down the spine itself. Visceral pain generally originates in the organs, and so if anyone's ever passed a kidney stone or developed hydronephrosis or swelling around the kidneys, people can have severe flank pain or back pain, which can be disorienting, and that is basically pressure from the inside of the organ out, pushing on the fascia around it. Can come from swelling of the ovaries, swelling within other organ systems, and even the GI tract. And then there's things like inflammatory pain, which is generally related to tissue damage plus inflammation. We can see this in autoimmune conditions, things like rheumatoid arthritis and lupus. And sort of the general cardinal signs of this kind of inflammatory pain would be like a heat and redness, a swelling, potential loss of function of a limb. And these are all things that you want to evaluate in patients who are describing this sort of inflammatory caused pain syndrome. So general causes for pain in the cancer patient is a lot of it's nerve pain that's brought on by a compressive process or injury, possibly through surgery or progression of the disease itself through the body. Bone pain from direct bone cancer growth or metastatic disease is pretty common. Soft tissue pain from organ expansion, as I mentioned earlier, also involving compression of a variety of nerves, including facial nerves. Phantom pain from amputations or causalgias can arise in patients who've had limb, sparing surgeries. And then referred pain through either dermatomal or peripheral nerve irritation. And there's a variety of reasons for developing things like that. And multiple myeloma, which is characterized by this neoplastic proliferation of the plasma cells, these cells basically proliferate within the bone marrow, and they can obviously spread out in the body. But when they involve the bone directly, it can lead to destruction of the actual architecture of the bone. And when that happens, you're left with cavitations and lesions in the bone, which lead to weakness, thinning of the bone in general, which is osteopenia, and then general pathologic fractures. Usually those aren't determined until x-rays are made, but a lot of people might come into the ER saying, hey, I got out of bed and I was walking to the kitchen and I kind of tripped over, the rug and broke my leg, or I slipped and rolled my ankle and now it's broken. Or they get bumped into, in a dance class and they fracture a rib. So all these things are considered sort of, the trauma doesn't equate with a fracture in normal parlance, but it equates to a fracture when the bone is diseased. So these significant changes, obviously, if you have a fracture, there's severe pain, and then ultimately, if it's expanding in the bone, it can cause deep aching, and really, in some cases, what patients describe as unescapable pain. They can't get out of that pain, and it's very persistent. If it involves something like the kidney, which can be involved in multiple myeloma, flank pain or low back pain become pretty oppressive. These are just some cartoons or pictorials around what healthy bone looks like versus what happens within the diseased bone. And a lot of the cells start to push out some of the normal cells that are used to remodel and build the bone. And in the process, you can develop little microfractures as well as just divots and cavitations in the bone, thus weakening it. On this slide, I have some pictures of some fractures that have occurred in between long bones, and mainly it's limb fractures, some not necessarily involving any underlying pathology, but certainly potentially either from trauma or underlying pathology. On the right side, again, you can kind of see that the multiple myeloma model does involve a lot of potential bone invasion and destruction if it's not dealt with in a timely manner. And of course, any of these mottled or diseased bones are, increased risk for these pathological fractures just by doing, day-to-day activities. So pain management oncology, there's several tools that we use that allows us to put sort of pen to paper around somebody's quality of life and how we indices these complaints. There's some really simple ones that we use, and then there's some more complex ones where we look deeper into their quality of life. A common one that's used is the pain management index, and I can show you an example of this. Some of you folks who are dealing with multiple myeloma now may have actually filled some of these out. The other one is the myeloma patient outcome scale. Basically, it looks to assess the quality of life for multiple myeloma patients and also deals with aspects and experiences they have with pain. It allows the practitioner to kind of fine tune some solutions and programs that might provide some relief for the patient, specifically filling out the forms. Multiple myeloma symptoms and impact assessment tool is another way to measure symptoms and how it impacts patients. This first one is pretty straightforward, but it's basically a pain management index talking about the level of analgesia or level that they exist at. And so a level 0, there's no drugs on board. A level 1 is they're using like a non-steroidal, maybe Tylenol. Or level 3, it's like a weak opioid. People may be on codeine. And then level 3 is morphine, sort of a higher dose, morphine or fentanyl. And then pain level, what's the pain at this point in time? And so during the pain inventory, again, you're going to be asking these patients and you're going to be reporting to the doctors exactly how you feel. And then that comes up with a score. And so those scores are varied and they range between -3 and +3. Obviously, the goal is to make the patient as pain-free as possible without compromising other aspects of their life. And then going to the next slide is the Edmonton classification system for cancer pain. Pretty straightforward. It talks about what's the mechanism behind the pain. Is it a nociceptive pain? Is it a neuropathic pain? Or we just don't have enough information to address it. And then the incidence of pain, and sort of temporally, you can outline how often you're having pain. Is it come and go? Is it persistent? The psychological aspects of the pain, which we talked a little bit about before, but how it's affecting people. In general, when people are in pain that's not relieved, their mood, their emotions all change. And not only are they miserable, they're miserable to be around because they're suffering, right? And then addictive behavior, measuring whether for a fact if this patient had a history with certain substances, that has to be navigated and done so in a logical manner. As you know, multiple myeloma is really, from 20 years ago till now, has turned into a real chronic sort of stable disease where people aren't really plagued by some of the bad side effects if they're well controlled with medications. And the idea is that some of these folks need to have a plan to treat this pain for possibly the long term if it's necessary. But our goal is to use opiates as appropriately as possible, certainly within this environment. And then cognitive function on the flip side, how well are they thinking? How well are they processing? And cognitively, how are they doing? And that can be a mixed bag because pain can affect cognition. And of course, medications can affect cognition. So you want to be really mindful of that. And then this is kind of like the little frowny face to the smiley face profile. It's something very similar to what we use in the emergency room, and certainly we've used it with kids where they just kind of point to how they're feeling. Number 10 is the most severe pain. Basically, the person is writhing in pain. They're unable to move, may not even be able to talk. And then 9 is severe, 8's intense, 7 manageable, 6 distressing, 5 distracting. Really, anything above 4 is something that we kind of want to address. Really, some of our goals when we look at pain management is if somebody's, 4 or higher, then our goal is to really kind of bring them down under 4, close to 2, maybe even 1. A lot of times when we're managing pain in folks who are dealing with chronic pain or cancer-related pain, is to make it, minimal to mild. Many times, without a lot of medication being put on board, it's hard to get complete control of the pain unless we've really addressed the underlying disease itself and the disease is gone. Then the hope is that whatever recovery they're having would allow for them to sort of clear that sort of pain window in time. So traditional approaches to pain, I mean, there's numerous ones, right? There's, specialties in pain management where all these doctors do is just manage pain, acute and chronic. But at the end of the day, the underlying issue is to treat the disease. So with multiple myeloma, we have a variety of, new targeted therapies, monoclonals, and other agents. If necessary, surgery could be done, potentially radiation. But for any cancer, the goal is to treat the underlying illness. And with that being said, once that's treated, the goal is to start to close that window on that pain issue. Really, for symptom relief only is going to be like NSAIDs that help control some of the inflammatory processes. So things like ibuprofen and acetaminophen, very common over-the-counter meds, but we have to be careful with them. Ibuprofen puts a lot of stress on the kidneys. Acetaminophen can stress, and if taken in large amounts, even destroy a liver. Use of steroids. Steroids kind of have gotten a bad rap, but in general, appropriate use of steroids and steroid tapers can provide a lot of relief to folks suffering from inflammatory pain. Ultimately, you can give them orally, IM or IV. Acutely in the emergency room, we'll give them IV if necessary. And then now moving into the next level, which would kind of be the opioid medications. And again, we have a lot of internal battles as clinicians as to how much do we give, how long do we give it for, do we have a weaning plan, do we have a way to get them off of opiates in the long term? I mean, the problem is a lot of patients, they don't want to be on opiate medications. They're like, that's not my bag. I don't want to do that. But the side issue is that once they're started on it, and number one, they have reasonable pain relief, and they're sort of allowed to take some deep breaths and be human again. That's something they find appealing. And then the secondary issue is for some patients, there's quite a bit of euphoria that come with the use of some of these medicines, more so than others. So judicious use of things like morphine, oxycodone, and even fentanyl patches for folks who have trouble swallowing or taking pills orally, or if you just want a better steady state in the blood for your opiate medication. The use of anti-anxiety agents, a lot of people don't think about it, but pain is an anxiety-provoking issue. So cancer is an anxiety-provoking issue. So anybody who's suffering from pain is dealing with cancer, there's a high likelihood that they're suffering from some level of anxiety. So that needs to be addressed. And there's lots of ways of doing it. I'm just looking at the pharmaceutical approach right now. But things like lorazepam are very helpful to calm patients down. And in doing so, can bring about some perceived pain relief. Other things like muscle relaxants for folks who have started to carry extra tone in their musculature, whether they're guarding or protecting a pathological fracture, or just because they're in pain, they become a little hypertonic with their core muscular system. Sort of outside of that class, there's lots of other things we can talk about, but Flexeril or cyclobenzaprine is a common medication we use to relax the muscles. Outside of the drug cabinet, physical therapy is amazing, and I think it's really underutilized for our cancer patients as well as exercise. I think exercise has shown again and again its benefit not only for pain control, but also for recovery and long-term survival from cancer. So even though you may have been recovering from cancer in the process of treating cancer, there's a variety of low-impact exercises you can do that can be beneficial not only for your mental health, but also for the pain issues and for your disease state. And then, of course, simple things, applications of heat or ice. A lot of people, they think, well, I have severe pain. How is heat or ice going to help me? But without trying it or utilizing it in a way that's reasonable, usually it's 15 to 20 minutes on an area that's hurting you. And you can alternate between heat and ice and see which helps, or simply use both. Again, other sort of these are sort of second tier medications, but certainly within the chronic pain arena, very commonly used would be anti-seizure medications like gabapentin or pregabalin. They've been pretty common and over the past 20 years have been used quite a bit for patients with chronic pain. Antiviral agents, and a lot of people don't think about it, but anytime you're on chemotherapy or you're immunocompromised, you're more susceptible to having outbreaks of things like shingles. And when that happens, that can be horrifically painful, and the neuropathy that comes from that is pretty profound. So putting people on antiviral medications very quickly, if it turns out that they have an outbreak of shingles, can be very helpful, certainly for long-term control of future neuropathy once the rash is resolved and the shingles have regressed. The use of bisphosphonate drugs like Zometa may help protect the bone, prevent future fractures, and subsequently help with pain. Monoclonal antibody agents like Xgeva can also help protect the bone, and garnered a indication about 6 years back for multiple myeloma. Antidepressants like SSRIs and SNRIs are commonly used. Many patients, like I mentioned earlier, have anxiety if they have pain and they have cancer. There's also a lot of times their underlying depression there to be addressed, or dysthymia, and these things can help. Amitriptyline is an old drug that has kind of a double-edged sword. It's good for two things. It can make you a little sleepy, which can help for people struggling with sleep, but it also can help with the perception of pain. So these are going to kind of drift into areas that are probably not really traditionally offered by regular traditional docs that are just trained within the fabric of traditional allopathic medicine. But really, outside this country, is certainly in Asia and in Europe, some of these therapies are highly evolved and are used regularly to address pain. Acupuncture is probably the biggest one coming out of Asia. If anyone's ever had a reasonable or a good approach with acupuncture, can testify to its benefit. I personally have benefited from using acupuncture. Neurotherapy, which is brought to us by some physicians out of Germany, is a process of doing what we call chemical acupuncture. So going into some of these meridians or meridian points that have been mapped out by folks that have been doing acupuncture for a long time, were being injected with medications like procaine and some homeopathic remedies to help resolve chronic pain issues. And the last one's trigger point therapy. And trigger point, a little bit different than neurotherapy, really focuses on going after tender or pain points that people may exhibit. So if your doctor is ever poking on you or going down your back or going down your arm or up in your shoulders or neck and say, wow, does that hurt? And you're like, wow, that's really tender. Those are potential trigger points that can be treated with a little injection of things like, again, procaine, possibly even a little steroid. And there's more evidence to suggest that other therapies may be coming down the pipeline to include things that can help with actually healing tissue. Other very common things been around a long time include osteopathic and chiropractic manual therapy, whether it's myofascial release, cranial sacral therapy, and for patients who are appropriate, more high velocity maneuvers that you see people doing to take tension out of joints and certain aspects of the musculoskeletal system that can be bound up when people are suffering from pain. One of the biggest ones that I've been using for many, many years now is intravenous vitamin C. So vitamin C is able to have a variety of impacts, not only at high doses does it have an anti-cancer effect, but it also can reduce these pro-inflammatory cytokines, things like interleukin-6, interleukin-1, tumor necrosis factor, and C-reactive protein. And we can measure some of these things in the body and actually see them drop when patients have been exposed to high doses of vitamin C. So with bone pain, we've seen a lot of benefit, not only with that, but an agent called amygdalin, which is pretty commonly used outside the US, can be helpful for bone pain. So sound wave therapy, some people, equate that to, crystal bowls, right? Or to shock waves, like a pulse gun or a thumper. But ultimately, sound wave therapy is using sound, whether it be ultrasound driven or not, to create a relaxing and a therapeutic response within the body. And so some of these things that are done are very low vibrational items that can provide relief. And you can, body workers will use this kind of therapy. Not to say that crystal bowls and other agents don't help bring relaxation around, which can be helpful, but this is just a kind of a low frequency therapy that allows tissues to relax and can reduce the level of pain and inflammation in an area or flush some of those inflammatory factors out. Hypnotherapy is very powerful. And for those who are really susceptible to hypnosis, it's probably one of the most powerful tools I've seen for anxiety, pain, even nausea. I've seen people completely come out of some pretty uncomfortable situations being hypnotized. There's tools that you can go to a hypnotist and have that done, or you can undergo training for doing self-hypnosis. Biofeedback is another powerful tool that can be done using everything with like a heart rate variability, where you try to get your body to calm down in such a way that you can drop your pulse. You can do breathing techniques. Andrew Weil has some great resources when it comes to breath work and its role for taking you out of a sympathetic state, which pain will drive us into a deep sympathetic state, into more of a parasympathetic state where we're relaxed and calm. Emotional freedom technique, a lot of people may not be familiar with this, but it was developed years ago as a tool for almost like self-correction through giving yourself biofeedback. It works on a variety of sort of meridian points from the top of the head to the face to the chest. And patients will be given tools in which they can use this sort of feedback mechanism to calm their nervous system, as well as take away some of the pressure that comes from being in pain. And it's very powerful, and I've seen it used on numerous occasions. It's great, really, for calming if somebody's really anxious or they have stage fright, or they're just suffering from being overwhelmed from whatever condition they're in. Massage and therapeutic touch, again, powerful. Both are hands-on techniques. Therapeutic touch is a little bit of a combination of touch and energetic therapy. Massage is really mechanical. So whether they're moving fluid around, whether they're readjusting fascia, going in and releasing areas that are excessively tight, a lot of people do benefit when they have cancer, and it's one of the tools that we encourage people to explore when they're uncomfortable or having a lot of symptoms of pain. Reiki has been studied for many years, but it's a hands-off therapy in which the practitioner will sort of move energy around or influence energy within the body. And in doing so, patients seem to have a benefit. And the funny thing is that when I first started looking at Reiki, I had never had a session. I did a little talk on it many years ago. So I ended up going in and having a session, and I was impressed. I mean, I don't know, they always say there's a placebo and nocebo, but I felt as though there was something there. And as a physician and a scientist, I do recommend it. And I think with good practitioners that this can be very helpful with reducing pain and anxiety. Meditation is something that has sort of ebbed and flowed in popularity in the United States and abroad. What I see nowadays is that our ability to maintain focus and pay attention to things has really sort of been crippled in this age of technology, where we're really being diverted in so many directions and overwhelmed by laptops and phones and TVs and just interruptions throughout the day, that being able to set aside a period of time, as little as 10 to 20 minutes, can be profoundly helpful to find a quiet space where you're not going to be compromised with the influence of information. Some things like transcendental meditation are very powerful, and there's free online courses you can do. You can join, groups that do this locally in your community. And of course, things like hemisync technology. I was first exposed to that many years ago from the Monroe Institute, and they have this form of sound therapy that can really put you into like a theta, into a relaxed state that allows you to let go of a lot of tensions that you carry with your body unconsciously. Intravenous vitamin C, I just wanted to show you kind of some of the avenues it affects the pain pathways. There's a lot of things that can cause oxidative stress. Obviously, having chemo, radiation, surgery, dealing with a wound, and any other underlying inflammatory diseases. And this ultimately can lead to tissue breakdown and damage and subsequently pain. Vitamin C in of itself, if you have a sufficient supply of it, can interrupt some of these processes pretty directly. In fact, in many cases, it can boost your brain so you're no longer perceiving that pain the same way. It can blunt oxidative stress and then ultimately help you heal from some of the processes you're going through. It's a very miraculous substance, and I think Linus Pauling have brought a lot of information to bear around vitamin C, and over the past 40-50 years we've learned so much more about it. But it's certainly one of the most powerful tools we have in the toolbox that's a non-opiate for dealing with pain, and certainly bone pain. Again, some more integrative approaches we like to talk about deal with dietary changes. A lot of people, it's hard to think about what we eat as being maybe a cause of our pain, but there are a lot of things that we do eat that are pro-inflammatory, right? So that they provide us some of the building blocks of things that eventually become part of an inflammatory environment or microenvironment within our body. And there's a lot of people that have food allergies they don't even know they're dealing with. And in dealing with that, you end up upregulating parts of the immune system, which cause increased inflammation. So you want to be really mindful of that, and sitting with, a good nutritionist, a food allergist, a naturopath can really help enlighten you about what foods might be good for you and what might be bad. Fasting under medical supervision, I think probably if you were on an island and you had no other resources and you were forced to fast and you were in pain, you would see yourself probably finding some relief probably within 12 to 24 hours. Fasting can be pretty profound for interrupting the pain cycle. A lot of times the body will slow down what it's doing, including making these pro-inflammatory cytokines, and really put yourself into a conservation state. And in doing so, stop the release of a lot of these inflammatory agents that cause these painful cascades to occur. So fasting, again, under medical supervision can be a powerful tool. Dietary changes to increase anti-inflammatory foods, and I included a slide of a few of those. Big fan of exercising. We've shown over and over and over again that exercise, if you have cancer and you're not exercising, you're missing out on a very powerful approach to not only treating the disease, but increasing your quality of life and potentially extending your health span. So anybody who's dealing with an early diagnosis of multiple myeloma, chances are you're going to end up passing from something else in this lifetime. And the idea is that if you want to maintain a healthy, happy life, then you want to make sure you're well exercised and that you're in the best shape possible. And I think it's very possible with a variety of cancers to stay in shape. So whether it's walking, swimming, Tai Chi, yoga, stretching, lightweight work, or even band training, there's a lot of ways you can preserve, your musculoskeletal system, as well as bring some brightness to your mood and how you're feeling through the release of enkephalins and endorphins from the exercise process itself. So one of the most popular areas I ever get approached on as a clinician is the role of cannabis and cannabinoids. I had the pleasure of studying some of this stuff back when I was in grad school, and found it really intriguing that we first and foremost had an endocannabinoid system. So we have a whole system in our body that has receptors for these cannabinoid molecules, and it affects a variety of systems. It affects, the skeletal muscle, it affects immune cells, it affects the brain, obviously. So when I started exploring this area of medicine, I was acutely aware of the potential impact it could have on clinical practice. And for what I'm finding now is that with the majority of the states now offering medical cannabis, and probably just under the majority of states offering some form of recreational cannabis, it's readily available, at least in the US. And a lot of efforts have been made abroad to decriminalize it so that it can be made available as a medicine, because it has great therapies. In general, it can be recommended to be given topically orally, or you can vaporize it. Generally, we don't recommend people smoking it for, some of the potential bad side effects of smoking the substance. Some of the common cannabinoids that have been talked about and have sort of made the press are going to be things like cannabidiol, THC, and CBG. These agents all play a role in mitigating the perceptions of pain, anxiety, and can also help with muscle relaxation. On the cancer intensive side, we've seen great help as far as increasing appetite. In fact, we have several drugs out there that it's indicated for helping people increase their appetite, and then secondarily decreasing nausea. So as far as symptom control in its application to patients with cancer, cannabis covers a lot of bases, and I think it's a very powerful tool if used appropriately. Another medication that I'm really familiar with from working in the ER is ketamine. So ketamine is a medication we used a lot of times in children. It allowed us to treat children without jeopardizing their underlying physiology in case they were to have a reaction or needed more life supportive care. So it's a dissociative agent. It can help people sort of remove themselves from the pain process and allows folks to undergo either procedures or tolerate whatever pain they're dealing with. It certainly has indications in the world of anesthesia, but it also has indications for folks who deal with severe neuropathic pain or causalgia, phantom limb pain. They are more and more of these ketamine clinics that you're finding now, and their scope of practice is going beyond just pain. It actually now is used to be addressing underlying dysthymia, refractory depression, PTSD, and what we would call CPTSD, which is sort of this complex post-traumatic stress disorder. Anybody who's had cancer and who's had treatment for their cancer most likely has some symptomological aspects of PTSD. It's very hard to go through that process and not develop some of those issues. So I think ketamine may play a significant role for people who are long-term survivors or thrivers that are coming out of a cancer diagnosis. So it's certainly a tool. If you have questions about, you can reach out to your doctors, your oncologists, to check in with them to see what they think. Cryotherapy, it sounds kind of funny, but I talked a little bit about heat and ice. Cryotherapy is sort of the next level of cooling down. I like to always compare it to like what Wim Hof has described with these cold plunges. You can do a wet or a dry. Again, I would recommend under doctor supervision and never alone. You want to probably have some competent idea that you have the constitution and the cardiopulmonary capacity to get into, a very cold pool of water and sit there for 3 to 5 minutes or however long you need to kind of, get the benefits of the cryotherapy and then get out. It's very good at dealing with chronic global inflammatory pain in the body. And on the flip side, there's hyperthermia. So hyperthermia, we use near infrared and far infrared, and those can be applied locally or done globally to help deal with pain. Again, you want to find what works for you. The thing now is, in fact, because Wim Hof became so popular in the cryotherapy movement, there's now these dry machines. So they're basically like a water bed that can envelop you, not your face, obviously, but envelop you and expose you to that cold water, allowing for that cooling effect and the same sort of benefits you get from wet cryotherapy, which is sometimes the rate limiting step for patients who want to try it but are too scared to, or don't have the kind of support they need to basically do a cold water plunge. Sensory deprivation tanks, I've been in a few myself over the years, and it's a very interesting experience. The goal certainly is to help you sort of shift from a sympathetic state to a parasympathetic state. I think it was great for me. I had hurt my back playing rugby, and I found that the sensory deprivation tank was great at relaxing things, and I did notice improvement with my back pain. Ultimately, at the end of the day, I think it's something that if you have in your community is worth trying. If you're not claustrophobic. There's just a little idea of how cannabinoids interfere with nerve cell transmission for the conduits of pain. There's numerous areas where it can interfere, mainly through the CB1, CB2 receptor, TRPV receptors also involved. It's a little complex here on this cartoon, but at the end of the day, there are a variety of mechanisms of how cannabis interferes. They mentioned THC, dronabinol, nabilone. Those are those prescription medications I talked about. But these cannabinoids really can influence these pathways in such a way that you notice pretty quickly a reduction in pain and the sensation of pain. Again, this is another cartoon kind of describing the different receptors and how something like CBD would engage with them. For the most part, when I talk to patients, I do recommend a combination of both CBD and THC, depending on the type of underlying cancer they have. And the idea is to have them start slow and start to experience what they feel with the medicine, because not everyone's the same. Sometimes people will use this medicine and it's very activating for them, and those we probably would dissuade them from using it just because it will make them a little more hyper, a little more in a sympathetic state. Again, some other things we use to control pain include use of adaptogens. Common things like ashwagandha, ginger, rhodiola, ginseng have all been shown to help benefit with pain syndromes. Boswellia specifically blocks some pro-inflammatory cytokines. Can be a little tough on the stomach, so we usually have people take it mixed with ginger, and certainly take it with food. Curcumin blocks a variety of inflammatory cascades. I mean, I think there's over 500 different things that curcumin does within the cancer cell, and within the body itself that has some medical benefit. So it's a pretty powerful spice. Omega-3 fatty acids, inhibit NF-kappa beta and can influence negatively those inflammatory cascades. Mushrooms like lion's mane, reishi, chaga, turkey tail, all can play a role as acting as adaptogens to helping you manage pain. And common things that you've heard about these probably since the 70s and 80s: glucosamine, chondroitin sulfate, collagen, MSM, vitamin D, capsaicin, white willow bark, which is sort of early man's answer to aspirin, alpha lipoic acid, all can influence your pain experience in a positive way. Funny thing, a lot of times we don't ever talk about it, but sexual relations and the role of oxytocin supplementation. We know for a fact that if you have cancer and you engage in regular sexual encounters, that's beneficial to the pain, perception and feelings of pain. There's so many levels to that a lot of folks who aren't engaging in that, there's some fear sometimes around about, the partners or whoever they're having engagement with is either fearful of hurting their partner, or the partner's worried about, um, you know, contaminating their partner somehow. So I think a lot of education has to happen within that sexual relation segment of their lives, and I think it's critically important to have it early, and possibly often. I just met with several, folks this past week that it kind of came up as a question, like, is it okay, when my wife's taking X, Y, or Z, is it okay to have intercourse, right? And you just have to reassure and educate, and that can go a long way to recreating, in fact, some really new, beautiful bonds for patients who are struggling with cancer and pain. And then again, if you're alone, masturbation is obviously an answer, a potential answer for that, for increasing your oxytocin levels. And then, of course, just taking oxytocin orally, getting it from a compounding pharmacy, and taking it to help with significant pain issues. Here's a list of some anti-inflammatory foods. They're pretty basic. I'm certainly a big fan of fibers found in fruits, veggies, legumes, again, omega-3 fatty acids, a variety of polyphenols, which are in some of the supplements I just talked about, and then unsaturated fats, found in some nuts and seeds. So some future prospects for pain. There's a company out there called Vertex. It just came up with suzetrigine, which is formerly named as a VX 548, but they just got their drug application accepted in June of 2024. But it provides the same sort of pain relief that opiates do without the addictive potential. So this can be a big breakthrough for folks who need some sustained pain control over a period of time. The story isn't going to be finally written, at least probably for another year or so, but this is something I've been looking out for a while, because I've dealt with patients who've really suffered from managing their opiate use. Neurostimulation is another thing, whether it be through the spinal cord or peripheral nerve stimulation to help relieve pain. A lot of folks will look at, TENS units, and there's mixed data on those, but in many cases, if you have a peripheral neuropathy, you can get quite a bit of relief from a TENS unit or from an implanted pain device. And that would be done. That's more of an in-depth procedure, but what they would do is basically put a pump, not pump, but a stimulator in your back under your skin that would help mask the pain that you're perceiving. And I guess for that matter, we do have pumps out there. So if you need to use opiates for a long period of time, there are these intrathecal pumps that can be used that basically go into the spinal canal and put small aliquots of opiates into your spinal canal to control some pain. So that's another option if pain is so severe and you're not responding or handling the opiates well. That's another option. MDMA, of course, it made the news a few months ago that the FDA kind of shut down one of their trials that was going to allow it to be used in cohort for treating PTSD. So its street name is ecstasy, but MDMA basically is a medicine that very quickly puts you into a very, euphoric, loving space that's, I guess it certainly was used in the rave scene. It was used for, lots of folks going out to Burning Man trying to enjoy themselves. But in this sense, as a therapeutic agent, in early studies, it really showed quite an impression on people suffering from PTSD. And part of that subset of benefit was reduction in the sensation of pain, whether it be psychological or physical. So I think more work is going to be done in this arena with MDMA, and um, I'm hoping to see more availability of this item for certainly patients suffering from PTSD, but hopefully for pain in the future. Psilocybins, a lot of people know that psilocybins have sort of, no pun intended, but sort of grown up over the past 10, 15 years as far as popularity goes. But these magic mushrooms contain some serotonergic agents, psilocin specifically, that can help folks with, chronic pain. It was certainly shown to be very beneficial for folks who are dealing with cluster headaches. And we've seen some good success in the trials that have been done so far. We're, probably a year or two or maybe more, depends on how things go here in the US as far as regulatory rules go, to having psilocybin be available for patients who are suffering from pain. And there's also some good data suggesting it can help with refractory depression as well. Ibogaine, I don't know who's heard of this. I looked at this plant 20 plus years ago. It comes out of West Africa, and it's basically a native root used by the indigenous tribes of West Africa to treat a variety of illnesses, and also used for rites of passage in young men who are coming of age within the tribe. Ibogaine is basically a very strong psychogenic agent, causing pretty profound hallucinations in higher doses, but has been used to help people control not only addictive behaviors, but pain syndromes. So I think there's going to be more and more that we learn about ibogaine as a plant when it comes to taking care of pain. So these are some things that you may want to throw out in your Google search engine every few months to kind of see where things are at in respect to pain. But there's other applications for these as well. So I think the future is hopefully exciting in that direction. So in conclusion, pain sucks, and we don't want our patients in pain. I think it's probably witnessing the level of dysphoria and discomfort people have causes a great amount of moral injury for the practitioner, for the caregiver, but the patient is the person that bears the brunt of that, and that's overwhelming. So our goal is to really step in, make early measurements, monitor their pain and manage their pain, and really meet the patient where they need to be met, and honor and acknowledge their autonomy in getting pain under control. Many years ago, it was called the fifth vital sign. Technically, it is. It still is the fifth vital sign. And that pendulum has swung back and forth from really easy access to opiates to now, somewhere in the middle between no opiates and still managing the patient's pain. So I think as a culture in the US, we're getting better at addressing this issue. I don't think there's any question in my mind that pain management should be at the forefront of your mind when you're caring for a cancer patient who's suffering. So again, quality of life, you want to focus on the patient's journey. It's going to be rough. They don't need to be in pain, and you want to control that as much as possible. Beyond pain reduction, you want to help them with anxiety, if they have nausea, which is very uncomfortable, depression, and focusing on sleep. Getting restorative sleep can be very influential for patients who are struggling with pain, and it helps them recover from some of the processes they're going through to treat their disease. So we really believe now it looks like eight hours on average is kind of what you need of sustained deep sleep. Working with a good traditional physician that specializes in pain management is helpful. Finding a good naturopath who's savvy in the natural realm for addressing these sort of things, and a good functional or integrative medical doctor can go a long way in rounding out your comprehensive approach, really not only to the pain, but to the cancer diagnosis itself. So those are some of my pearls and insights around this. I just wanted to share a few more slides that have some books on them that are great resources. So these are some of the books that sit in my library that you guys probably would enjoy reading. There's many, many more, but one on herbal medicine for pain management. Again, the anti-inflammatory diet, cannabis for chronic pain. That's a little bit more of a deeper dive, but kind of explains the mechanics of how that works. Mindfulness and meditation. John Kabat-Zinn is amazing in the explanation of using meditation for pain relief. There's some pretty easy to do practices in there. And again, exercise for pain relief. Unlearned pain deals with some of the psychological aspects of pain and how we can best serve ourselves by sort of thinking in a more richer way than we have been, and getting out of some of that monkey mind that can consume us. Cold therapy and pain. This is a very interesting book, sort of addressing some of the benefits we've seen with Wim Hof and what he's done. Intermittent periodic fasting. Walter Longo is one of the editors of this book, and he's done some of the deeper research on the role of fasting in treating cancer and a variety of other conditions, autoimmune issues, metabolic issues. It's a very good book. And then clinical hypnosis for pain control. If you can't find a hypnotist, there's some resources like these can help you with self-hypnosis. So don't hesitate to reach out and look for some of those things. So Cindy, thank you so much. Thank you guys for listening.
Great. Thank you so much, Dr. Devlin. We're going to open it up for some Q&A. So if you've got a question for Dr. Devlin, now's the time to ask. You can go ahead and just type those in the Q&A box on your screen. And we've got one already from Sally. She's asking, when I had deep bone pain prior to my stem cell transplant, I was advised to use Claritin. And she said it actually worked better than the pain meds that were prescribed by her oncologist. Is it because it was an antihistamine?
Yeah, that's the main benefit that you would have. And that's just another part of the cascade of events that happen when we're injured, is the release of histamine. So that was a good call by the oncologist to recommend that. Absolutely.
I love it. Thank you. I've got another question that says, can you talk about stem cell therapy for pain?
Yeah, I guess I can. So this is a very sketchy conversation when it comes to people with cancer and giving them stem cells. In general, unless you're part of, a bone marrow ablation, process, and you're getting stem cells from a donor autologously from yourself that have been harvested, stem cells from other sources, whether they be pluripotent stem cells or mesenchymal stem cells, those things, really the data isn't there yet, and I haven't seen the safety data around giving them to people who have active cancer or an underlying diagnosis of cancer. But in general, if you're talking to somebody who's has an orthopedic issue, whether they have arthropathies or chronic deconditioning of a joint, then yes, then stem cells can be beneficial. And there's lots of clinics outside the United States that are doing it, Panama, Mexico, the Caribbean, that are actually using, pluripotent stem cells and mesenchymal stem cells. And in some cases, autologous stem cells that come from your fat or are taken from your blood and spun down. But in general, the concept is to use younger stem cells in an effort to help recover some of those joints. Right now, we don't have the data on doing that safely within a cancer patient population. That day is coming. I think we're going to learn a whole lot more in the next few years about that. But right now, I think there needs to be a line drawn between the cancer patient and the sort of the longevity, or the wounded warrior kind of situation where they're looking to recover a painful joint or recover stamina. I think there's so many things that can help. There's some of the studies that I've seen coming out of a couple of studies coming out of Case Western have demonstrated people with like fibrosis of the lungs or cardiopulmonary issues have benefited from stem cell use in the way that I've talked about, that's sort of not cancer related.
Perfect. Thank you. I love that question. That's a new one for me, so I'm gonna have to look more into it. So thank you, Eric. I've got one asking about meditation. They say that meditation is difficult for me. I can't focus or clear my head. Any recommendations?
Yeah, so I think, and this is not, you're not lost and you're not alone in this whole thing. But the fact is that some people will actually use lower doses of cannabinoids. I don't, a lot of people would recommend even using a little bit of alcohol, but I'm not a big fan of alcohol. And there's a lot of data out there that suggests that alcohol is potentially pro-carcinogenic. I mean, that's really where the data lives right now. So low doses of cannabinoids of either the indica type or a hybrid type between sativa and indica can be very helpful at helping you get into that parasympathetic state. It's sort of like talking about sleep hygiene. You need to have meditation hygiene. That requires that, the kids aren't running around, that you're in a quiet room that's basically, near body temp, like warmer than you would normally think. that you can relax in but not completely fall asleep in. Generally, people recommend that you either lounge instead of completely lay down. And then there's things like box breathing, 4 seconds in, 4 second hold, 4 second out, 4 second hold, and then 4 second in again. Those techniques and those breathwork tools can help build the practice. But it's like many practitioners have said, you have to sort of mind the gap. Try to find the space in between your thoughts and focus on that nothingness. And that's kind of the one of the major tenets of transcendental meditation, is to let your monkey mind run wild and just observe it, just watch it, but try to go back to that space of silence as much as possible. Try to visit it over and over and over again. Ultimately, the best type of meditation is done sober, right? But if you need an assist, I think some people have used, and to some benefit, a little bit of cannabis to kind of get into that more parasympathetic state where they can be more mindful of the gap.
Perfect. I love it. My youngest just taught me about box breathing, and it's been something I've used already just as a calming mechanism. So I think that's wonderful. We've got a couple that just say thank you so much. This is very informative. So just want to make sure you got that. Um, and then I've got two that are asking about red light therapy. So one also asks about infrared sauna and red light therapy, and they're wondering if they're helpful for pain relief with cancer.
It's a good question. And so there's been, because you'll hear all points of view on light therapy for people dealing with cancer. Some people are against it. They say there's a potential for promotional component to it. But a lot of people don't use it, don't even know enough about it. But the red light therapy basically is supposed to activate some level of healing and recovery for the areas that it penetrates. So a lot of times, if people are athletes and they exercise a lot, they can go in there and simply note that they're less inflamed. They feel more relaxed after red light therapy. As far as the sauna goes, there's a real heat component to that. And that, again, some people argue that that's not healthy or not the way you should do it. But of the infrared ones that I know about, if you have a targeted area that's hurting or bothering you, it's a bad hip or knee or elbow, then using near infrared therapy on that joint or area can be very beneficial. But if you're looking for a whole body experience, generally it's going to be your far infrared. And I would just talk to your practitioner, whoever you're working with, to see what their thoughts are on it. There's, of course, dry saunas and wet saunas. There's a variety of ways you can go. Some people will just like get a far infrared sauna and that'll be their go-to. But there's many avenues to look at. So, but be mindful that there's mixed data out there. So if you're dealing with a real burden of cancer, you want to be mindful what machines you're getting in and what tools you're using, because there may be some potential negative aspects to them.
Perfect. Thank you. I've got another comment and then another question for us here. So first comment just says coming off long-term pain meds can be very dangerous. Must do it under the care of your doctor. I like that reminder. Of course, it's really always important to um, make that connection with your doctor when making these changes. That actually leads me into one quick question I had, which is if somebody is looking for a physician or a practitioner that is well versed in these alternative methods, what's the best way to look for them? Are there specific qualifications that would be good to look for?
Yeah, anybody that's obviously licensed to be a clinical provider. So there's MDs, there's DOs, there's naturopaths, doctors of physical therapy. Some of these folks are well versed in some of the exercise tools and rehabilitation tools. Ultimately, somebody that has experience doing pain management is really helpful. Ultimately, you can find folks through there's a functional medicine academy, and there's A4M is another big academy that sort of has taught doctors stuff that exists sort of outside the box of traditional medicine. I know ACAM is another group, but there's several groups out there. But you want to look for like a functional medicine physician or an integrative medical practitioner that has some experience doing pain management and harm reduction, right? Because we always talk about when people come off of opiates, that effort is sometimes referred to as harm reduction, right? So we're trying to reduce the level of a drug somebody's on to prevent them from having an adverse event while on the drug. And that harm reduction process requires experience and training. And the prior question about like getting off of these opiates is very hard. And sometimes people they don't ever get off the opiates because they just, for whatever reason, they're not able to make that transition. Some people would argue with that, but unfortunately, I've seen people who either for underlying, mental health issues or brain chemistry, they can't tolerate coming off even low doses of opiates because they need it just to have a quality of life.
Yeah, absolutely. All right, Dr. Devlin, I apologize to those who didn't get to their questions, but I want to be respectful of everyone's time, specifically Dr. Devlin. So with those unanswered questions, I will look for some resources and put those in our follow-up email. So thank you so much, Dr. Devlin. I know I learned a lot, and it was wonderful to host you today.
Thank you, Cindy. It was a pleasure. So good luck to you guys, and thank you for joining us today.
Perfect, thank you. I'll go ahead and share my screen, and we will get through to the end of our session today. So perfect. So I'd like to take a moment to share something really exciting with you all. One of the most powerful things about our community is how we come together to make real change happen. Right now, we have an incredible opportunity to advance blood cancer research. We're working to power 100 research projects that will change lives. If you feel called to participate, you can contribute in two meaningful ways. First, by sharing your medical journey by joining the HealthTree Cure Hub registry, because your experience matters and can help researchers understand patterns they may never see otherwise. And second, if you're able, do a donation and sharing this fundraiser with your family and friends. All donations will go directly to research. In our follow-up email, you'll receive the link to join HealthTree Cure Hub and to donate. Thank you all for being an integral part of our community. It is our goal to make meaningful change in your lives through this initiative. As you leave the session today, of course, you'll have the opportunity to take the 2 to 3 minute survey. This helps us better understand the topics that are interesting to you, things that we can do to help create a better community. So I just want to encourage you to do that. Also, we've got some great upcoming events. This Thursday, November 14th, the Pacific Mountain and Southwest region will get the opportunity to hear about HealthTree's regional cure teams. This will be at 11 Mountain Time, 11 a.m. Mountain Time. It says p.m., but 11 a.m. Mountain Time. So be on the lookout for that if you're in those areas and want to join. And then Monday the 18th, we have a nutrition in the gut microbiome webinar. Will be at 5 p.m. Eastern Time. Tuesday the 21st, our Black Myeloma Health Community will be celebrating caregivers by discussing the heart of care, multiple myeloma caregivers sharing their stories. That'll be at 2 p.m. Eastern. We have many more virtual and in-person events in the works, so stay tuned. The link to sign up for any of these events and many more is found at the bottom of this slide and will be sent out to you in the follow-up email as well within 48 hours of the event completion. I'd like to again thank our sponsors, Adaptive, AbbVie, Genentech, Johnson & Johnson, Pfizer, and Regeneron, and Sanofi. And finally, I just want to say thank you all for helping us build our multiple myeloma community. And I hope to see you again soon at one of our events. I've got my email on the screen. So if there's anything I can do, please don't hesitate to reach out, and I hope to see you again soon.